To my very esteemed learned seniors, dear colleagues and friends, thank you Hyderabad Menopause Society for calling me and for inviting me to give this zara hatke dil dhadakne wala topic. आप लोग सब यहाँ पे आ जाइए because first of all the screen is very small and there is no visibility. I hope I'm audible to everybody. Sandhya Dixit ma'am, able and friendly leader, awesome. I worked with her and enjoyed her friendship very much and her impeccable team. The kind of work they've been doing over the WhatsApp over the last few days is like really heartwarming. So let's start on this topic which was given to me. I hope what my understanding I share with you and I hope to get a lot more insights from the audience. So sexuality is important to women. You all agree? Even elderly women. And I wondered whether this is a psychiatric topic or a gynecological topic. But then I got to the understanding that because it is a psychological, physical and hormonal interaction, it is both. Let us talk of the sex pathways. The sex pathways in the brain, the insula, cingulate gyrus, orbitofrontal cortex. So these are the central mechanisms and the female genitalia are richly innervated by nerve fibers which transmit tactile and pleasurable sensations to the brain. And we have the excite hot and the inhibit not. So what is the tipping sexual point? Okay, these are the red ones. I think nothing is visible, no? Itna chota, matlab. So you have to just hear me, okay? Serotonin, prolactin, opioids, they dampen the sexual drive. Dopamine, norepinephrine, melanocortin, and oxytocin increase the sexual drive. So that is why they say SSRI causes decrease in sexual drive. Why? Because selective serotonin reuptake inhibitor will increase the serotonin. Okay? This is something which we need to know. Now, what is the working classification of sexual dysfunction? Silence, please. Excuse me. Audible nahi hai, sunai bhi nahi de raha. Thoda sa silence. So there is, basically there is a sexual desire disorder in which there is a problem with desire, there is a sexual aversion, okay? You have arousal issues, then there are orgasmic issues, and then you have the pain disorders which we are very comfortable with. Dyspareunia, vaginismus, yes, we know what to do. The others we are still wondering. Now they have combined this sexual arousal and desire disorder together by the recent classification and they have made it as female sexual interest and desire disorder. So now instead of HSDD, I may be saying it as FSIAD. So kindly don't get confused. So what is it? The thing is, it is persistent, it is recurrent. There is a deficiency in sexual thoughts, fantasies, willingness to initiate and participate in sexual activities. And what is very important is, there is a distress. The lady is distressed, the relationship is distressed. That is the most important. If both are happy about it, it is not a HSDD. And why menopause? Because in menopause there are changes which can impact sexual health and HSDD is one of the common sexual disorders in menopause. So what happens? What are the special considerations? Why should we be more worried? Okay, menopausal women having issues, they need to concern. They are worried about it. But what about a young premature menopausal woman? What about an iatrogenic menopause? They will have huge issues, because they have to deal with quality of life, sexual well-being. Sometimes they may have grief of infertility. What about surgical menopause? Endometriosis, sab kuch nikal dete. 39, I have seen centers where they say that you have to remove everything. There is no other option. What about them? They are going to really have this problem. And men also are affected. Thankfully, yes. But we are twice as affected as men and it does increase with age. So now let us get to the cause. Do I have your attention, everybody? We don't really talk about sex and sexuality, right? It is something new for me also. And I'm just exploring this topic. There are biological factors, we all know about it, psychological factors and social and cultural factors. So we know very well the vulvovaginal atrophy which is causing painful intercourse, reduced blood flow to the entire genital area, the clitoris, the labia, so it affects arousal sensation. The fluctuating hormonal level, the lady is never ready for anything because there is fatigue, there are mood changes, unpredictable sexual responses. And testosterone, yes, testosterone directly contributes to the hypoactive sexual desire. So why testosterone natural decline with age? And during menopause, why ovarian and adrenal testosterone drop, and what is very important is in a surgical menopause, the kind of testosterone drop is double that of a natural menopause. There are psychological and emotional, body image, we all know about it, body image changes, there are mood disorders, stress fatigue, cultural and social, अभी हम तो बुढ़े हो गए, अभी क्या है, I mean इसमें बात नहीं करते, but then internally there is a problem somewhere. What about other factors which help? It is the partners. The partner also could have erectile dysfunction, he could have other sexual issues. You're not able to communicate with your partner. Supposing you are interested and he's not, or he's interested and you're not, the communication is not there. And there are general relationship stress and strain. The mother-in-law issue is just gone, sister-in-law has gone somewhere, brother-in-law kahin chale gaye, bacche unke daughter-in-law. Itne sare issues which can cause an issue with your partner. So everything affects in your sexual desire. Now let's come to the chronic conditions like diabetes, heart disease, thyroid, breast cancers, yes, neurological conditions, medications, especially SSRIs, any antidepressants, anybody on medications for psychosis, yes, any surgeries like hysterectomy, oophorectomy, we all just do it like that, but then it does have an issue, and especially if you try convince it to the surgeons, they don't agree, because I remember giving a talk about this in my own hospital. And then क्या बोलूँ पहले से ही HSDD है अभी से ऑपरेशन के बाद क्या improve होने वाला है. So that is the attitude, but it does affect. Does it affect? Yes, there is emotional distress, there is a feeling of sadness, frustration, relationship strain, reduced self-esteem, and sexual health is an integral part of holistic well-being, and its decline can affect overall happiness and life satisfaction. We need to understand this in our busy medical practice. So what is the diagnosis? They must show distress that they are having a reduced ability to feel sexual desire, and it must be for at least a period of 3 months. And before 3 months, she should have been normally participating in sexual activity. So how do we diagnose? Ask the questions about sexual well-being. Women will not be willing to initiate. Nobody will complain. You may find the husband coming and saying, Madam, he'll be prodding his wife, bolo, bolo, bolo. He goes out and then the husband says, and then she says, ki, inko always interest hai, mere ko nahi hai, kya karo? And so we need to actually gently question them and come out, because they may not be wanting to open up about it. There are validated tools, and there is no point in doing any hormonal levels. It doesn't really make sense. And finally, what are we going to do? We will take the gynec history, find out what is the menopausal status, whether it is premature, whether surgical, whether she has dyspareunia, vaginal atrophy, endometriosis, PID, prolapse, pelvic floor disorders, SUI, all these can cause. Of course, that is our job. And then we also find out if they are on antidepressants, antipsychotics, corticosteroids, letrozole. Yes, these do cause. And what are the management strategies? The most important, which my previous speaker has very beautifully brought out. Lifestyle modification encompasses everything. जो भी exercise करो, healthy diet, healthy attitude. I think beyond all this, it is the mind. If your mind is in control, it can control every other part of the body. So this is very important. Alcohol and smoking, yes, we don't have an issue too much about it, but of course it's there in the West. Open and honest dialogue with a partner. You need to be open about it rather than sitting and worrying internally, not knowing what to speak about. Sexual therapy, yes, we need to find out qualified sex therapists. There is something called as individual therapy, couple therapy. We always give moisturizers. We know to give lubricants. All that we know. Treatment options, psychotherapy, there is so much about it, and we really need to identify sexual therapists. It is a need. And till today, I haven't really nailed down on one person who can help my patients. Okay, so cognitive, if you have any contacts, you please give them to me, because I need to refer so many of them. Cognitive, motivational, cognitive behavior, there is something called mindfulness, sensate focus, sex therapy, counseling. These are all available. What about the pharmacotherapy, hormonal and non-hormonal? We all know that estriol is the first line treatment. Estriol, Premarin cream, they are the first line treatment for vulvovaginal atrophy. What about MHT role? It is not primarily used unless we use it for some other condition like VMS. We don't use it for this primarily. Tibolone is great, mood elevator, improves libido, but not primarily uprate. What about other thing which is important is, if she is on oral estrogens anyway, The oral estrogens increase the sex hormone binding globulin. They can reduce the testosterone. So switch to a transdermal. So if somebody on oral says that I'm having issues with sexual desire, change it over to a transdermal. Now what is this intravaginal DHEA? I think it is not available in India. Yeah, there's something very beautiful called as prasterone or intrarosa. Vaginal DHEA is supposed to be great both for vulvovaginal atrophy and for improving the sexual desire also, because androgen receptors are present throughout the urogenital tract. Now testosterone is, I think, the wonder drug for HSDD, but it is not licensed except in Australia. So how do they give, why it is not licensed? Because we don't have long-term safety profile. So maybe in the near future it may come. Patches are widely used, and the testosterone levels have to be maintained in the female physiological range, which is 1/10 of that of the male physiological range. So what is normally used? 300 micrograms per day patch. Sexual activity increases by 73%. So the guys are going to be really thrilled if they know that their wife can be given a testosterone patch. Takes 2 to 3 months for the clinical benefits to be visible. A maximum use is supposed to be for 1 year, followed by a drug holiday. Adverse effects are androgenization, like acne, deepening of voice, etc. We need to monitor the lipid profile in LFT because we know that testosterone can disrupt all these parameters. Now there is a drug called flibanserin. Flibanserin is a female Viagra which is given left and right in the West. I did consult and speak to several psychologists. Is anybody giving flibanserin in India? They said no. We have hardly given flibanserin in India. But this is known and it is given in the West because women demand it. Okay. So this, what does it do? See, all these drugs, what do they do?
Last 2 minutes.
Yeah, sure. It decreases the serotonin, increases the norepinephrine and dopamine. Bremelanotide is a melanocortin agonist. Again, stimulates dopamine in the areas that regulate arousal, motivation, appetite. Bupropion is an antidepressant, which again increases dopamine. So what happens is you have to diagnose promptly and treat them adequately. And what are the challenges? The women don't ask for help. We don't ask them questions. And the patients don't trust us. Can they really handle our problem? They have, and I accept that many of them don't know how to deal with it. So what we must do, like what we are doing now, this wonderful topic, I don't know whose idea it was, but then it's something awesome. And then do not believe that sex is not important for the elderly woman. Try to break the ice. And team-based approach is very important. Sexual health specialists, psychologists, pelvic floor therapists, we need to have a big gang of them with us so that we can help our patients. So prioritize her well-being. Sexual health is very important. Empower her. And well, this is how the woman should be. Kindly have a look at this cartoon. It's very nice. Look at this confident woman who says, what would you like to know? Thank you very much. This is a team approach, and let us help our patients improve their sexuality. Thanks a lot.
Thank you, ma'am, for your time. And it was very nice.